Hello, we're going to talk about trauma today. And one thing about trauma is everybody has their own definition of it. This actually came from a young lady who had lost her fingernail and couldn't come to school because it was such a traumatic event. However, trauma has many causes, lots of outcomes that we hope would not see. Okay? And that's the type of trauma we're going to talk about today. So basically, it's a severe life-threatening injury, and it's among the 5 leading causes of death in the U.S. And you can see the majority of them are motor vehicle accidents until you hit about age 65, and then falls will start to take over at that particular point. The economic impact, if you look at this, is billions, greater than $480 billion per year. Annually, it kills 3 times as many people who died in the Vietnam War. It temporarily disables 9 million people per year, permanently disables 350,000 per year. And in the U.S., any given 10-minute period, you're going to have 2 deaths and 370 disabling injuries from trauma. So you can see there's a lot of things going on. Unintentional injuries and homicides for ages 1 through 44 are 43%. From ages 1 to 4, it's 48%. From 5 to 14, 62%. Okay. And so, like I said, you can see the motor vehicle injuries. Other things are falls. As I said, once you get about 65, that's when we start seeing those. Drowning, gunshot wounds, fires, burns, stabbings, assault. Sadness, okay? One of the things that kills a lot of folks with the motor vehicle accidents or falls are blunt chest trauma with injuries to the heart, so the great vessels. How do we take care of this? Education and trying to get people to buy into the fact that they need to do some things to go ahead and take care of themselves. What we don't address in trauma are the emotional and physiological and psychological trauma that others suffer as a result of what happened to their loved ones. And this is something else that we need to take a look at. So just to show you this, okay, so this, as you can see, this is a passenger, small vehicle, wasn't wearing a seatbelt, had a head-on collision with a tractor trailer. You can see most of his bones, including the orbits around his eyes, have been broken or shattered at this particular point. A Le Fort 3 fracture or craniofacial disjunction is a separation of all the facial bones from the cranial base with a simultaneous fracture of the sigmoid, the maxilla, and nasal bones. Okay, so one of the things this person survived, there's not a problem with it, but you now have to think about what the long-term effects of this are going to be. This is a person who was in a traumatic accident, and as you can see, he actually swallowed his partial. So basically, what is the mechanism of injury? Injuries occur when there's an external force applied to the body. And basically, the type and the amount of the force that's being applied is going to determine the extent of the injury. And basically, with tissue overload, this is when we see destruction, fractures, laceration, ruptured internal organs, okay? There's not much to support a lot of those organs. The types of forces we're going to talk about are compression. These are the most common type of force. The injury depends on how long were you in that compressed environment, how much force was behind it, and which area was in fact compressed at that particular point. Acceleration, deceleration, most of the time we think about this with automobile accidents. It can also happen with airplanes. It can also happen if you're diving off the top of a ledge or a bridge to go into the water before. You're picking up speed, but as soon as you hit that water, now you're decelerating at that particular point. And then shearing is when organs shift, and when they shift, they run into each other. Sometimes the shearing will break the holds of the ligaments, the tendons, whatever else happens to be holding that at that particular point. And then cavitations, you have permanent or temporary, more elastic tissue. You don't see the damage quite as long, less elastic. We do see those damage quite often. If you look at the last time you gave blood, you probably can still see the needle mark where it was. Sometimes if you've cut yourself, you have a cavitation, and sometimes you have a scar simply because it doesn't heal all the way. So as you can see, depends on what happens. On this one, as you can see, it's the entry-exit wound of the hand following an accidental discharge of firearms. Remember, they tell you before you clean a gun, always make sure there's nothing in the chamber. So what are the types of trauma? Basically, 2 plus 1, mainly 2, but sometimes they use 1 as 1, and we'll talk about that in a moment. Blunt trauma, you don't necessarily see it. It doesn't necessarily show up right away. I'm not sure how many of you guys have ever been hit with a baseball bat or hit with a fly ball or something like along that line. You know, you can see a little red mark. You don't think much about it, except it really hurts. The next day, you have a massive bruising, and it hurts even more at that particular point. Penetrating, we can pretty well see where that is. We don't know where it always goes, but we do know that something actually went into you at that particular point. And then sometimes they'll talk about crushing injuries. We link these to blunt trauma injuries. Think about a crushing injury. For example, you're walking somewhere and someone has a pallet of heavy boxes and they come along and drop them on you, and they drop them on your leg and your foot. That is a crushing injury. It's also a blunt trauma injury. With trauma, you have 3 death periods. One is you immediately die. You die within seconds to minutes after you sustain this injury. Early is like the first 2 to 3 hours after the injury. In the latest, the days or weeks after the injury. And you guys have heard about the golden hour, critical care hour. This is what the trauma system is based off. And as you can see, we're talking about the morbidity, mortality that happens at the beginning of the event to 60 minutes later. There's your first hour. And what you want to be able to do is make sure, and this is what we're trying to do, is that these folks that are in these type of traumatic events are taken to the hospital, the trauma center, as soon as we can get them there. Now, one of the stories was kind of an interesting one, talked about a young lady who was over in Europe. She was in a car accident in a tunnel. A physician saw it. He called 911. She was still alive. She was in the back seat of the vehicle. 911 folks showed up. When they did, they started working on her. They kept her out of the hospital for over an hour. She was alive when they got to her, and she died before they got her to the hospital. It was like 15 minutes away. And in case you're wondering, that's what happened to Princess Diana. So the first thing we're going to talk a little bit about is traffic. And this is a typical day in Phoenix. Actually, it's in California, but this is close. So motor vehicle crashes. These are kind of old statistics. They've changed a little bit. 1999, more than 3 million Americans were injured and over 42,000 killed in motor vehicle accidents. You can see a lot of them were teenagers, young children, and people 65 and older. Half of them were not wearing seatbelts. And we still have folks who are driving around today that are not wearing seatbelts. All of you probably know somebody who said, if I were wearing a seatbelt, I would have died in the engine crash, but because I got thrown out in the roadway and missed the tree, I'm alive. Okay, that does happen on occasions, but not as often as people would like to have you believe. Alcohol was involved in 38% of the fatalities, but that one hasn't changed much unless it's getting worse. And aggressive driving involved 1/3 of the traffic crashes and 2/3 of the fatal crashes. Okay. Rates for males that are injured is twice that for females. Okay. And basically, they estimated that by last year, over 40 million older adults would be licensed drivers by 2020. And basically, older drivers are less likely than younger drivers to kill others in crashes. Ages 16 through 34 have more fatal driver crashes than others do. So based on the type of accident you have, and we're going to talk about some of these, can tell us where these injuries will occur. And then sometimes it can also tell us a lot about what's the patient is going to survive it or not. One of the things, and this was a number of years ago back east, there was an accident, and the folks went out and they rescued the folks to bring them to the hospital. And the EMS folks called in and said, listen, there was a backseat passenger. When he hit the back of the driver's seat, there was a black plastic bag, and his facial imprint was on that black plastic bag. And the folks in the emergency department told them to bring that bag in because they were going to be able to determine how badly this patient was injured. Something else that they do with this too is that they can look and see where are your deficits. Remember we talked about cranial nerve 3 that controls your eyes and your eyelids and things like that. Well, if they're not functioning, then they know that part of the damage of your traumatic event is now affecting that and that portion of the brain. So there's new things coming out all the time that try to help us so that we can take better care of our trauma victims. So there it is, the extent of the injury. Where are you sitting? The most dangerous seat in the vehicle is the front passenger seat. You have nothing in front of you except a dashboard. The driver at least has the steering wheel. People in the back seat, they have the back of the seats and everything like that. But you want to make sure that you still use restraints. Now, a lot of you folks probably take your animals or your fur babies with you on trips and everything, and you say, well, this little one only weighs about 30 pounds. If you get stopped in some accidents, that little one is going to weigh 300 pounds, and you definitely don't want them running into you. So it's always good to make sure that you restrain them also. And this is basically came from the CDC and everyone. During your lifetime, you have a chance of having a crash every 10 years with a 33% chance of disability. So the first one we're going to talk about is head-on. What happens is you're going down the road, you and another vehicle run into each other. The energy, which is based on the speed of the two vehicles, is going to be transferred if one vehicle is going faster than the other. If one's going 70 and one's going 50, 20 portion of the energy is going to be transferred to the vehicle that was going 50. Okay? Your front end will stop in less than a half a second. The rear continues forward because you still have a lot of energy in that vehicle, and the front of the vehicle gets destroyed by the rear. One of the students one time brought in an accident that they were in, and the engine was sitting in the front seat next to them. Okay. Two things normally happen when you're in a head-on collision. One is that you travel downward into the seat and forward into the dashboard or the steering wheel. But a lot of times your knees are going to lead the way. Your upper legs will absorb most of the impact. Where we're going to see some problems are with your hips, with your knees, with your ribs if you hit the dashboard, also with the femur and other portions of that lower portion of your body. Up and over, this is where you're actually going to go, up and over the steering wheel. And what can happen to you at this particular point in time is your head can go into that windshield or through the windshield. And now we're looking for spinal cord injuries. Most of the time when we have spinal cord injuries, they're either going to be up in the cervical spine or they're going to be in the lumbar spine at that particular point. Rear end collisions, basically what happens, you're sitting there and either you and the vehicle are moving forward or the vehicle's moving underneath you. And if the vehicle's moving underneath you, you're going to be pushed into that seat and you can have some damage that happens to you. Now, I don't know how many of you guys have ever checked your, what is it that sits on the back of the seat where your head bumps against it? I call it the head bumper. If it's not positioned correctly, you can cause some damage to yourself. So you want to make sure that if something happens, that if your head hits it, that it's going to be stabilized at that particular point. As you can see with this too, depending on how many vehicles are involved, you can have both a rear end collision and a head-on collision with the vehicle in front of you. Side impacts basically depends on, do you stay in place or does you move with the vehicle? One of the stories I tell on occasions when we were back here in early part of the 80s, we had a young man who was in the military. He was driving home, got into an accident. They found him. Fortunately, somebody called 911. They couldn't figure out what had killed him, and what had happened was he slid across the seat, and when he did, he hit the lock mechanism on the door, and that went in through his temporal lobe and into his brain and then ended up killing him at that point. Okay. The other thing that can happen is if you're sitting there, force goes into you because all that force has to continue on at that particular point. If you move away and you move with the vehicle, whatever accident injuries you're going to have in that accident will depend on what you strike as you go through the vehicle if you're not contained in it. This one shows you a little bit with this. This is a lateral collision of a car with a pedestrian. You can see how the person is bent over. They're going to definitely have hip injuries. You can see they have a femur fracture, some other spinal cord injuries, things along that line. Now, part of the reason I have this here is we think, well, this is just something that's happened to their lower portion of their body. And I'll agree with you, that is something that's happened to the lower portion of the body. But what you have to be careful of is that as a result of these broken bones, you're releasing some of the yellow marrow and some of the fatty tissue within the bones. And what will happen with these is these will turn into fat emboli. And as a result of turning into a fat emboli, they can go ahead and start moving, and they can end up in your pulmonary system, in your heart, or in your brain. So this is something that we always have to watch to make sure that that doesn't happen with these patients. This one's kind of interesting. If you notice, there was the pelvic fracture. You can see where it started and goes across that way. At one of the trauma conferences, one of the nurses was talking about this guy who was on a motorcycle. He was traveling down the street the wrong way. He ran in head-on into a car. The driver of the car actually called 911 and said, I can't find him. I know somebody hit me head on because it was twilight. He didn't have a good vision of it. The EMS folks came out. They couldn't find him. They found his bike. They found all the other things. And then they finally just said, we just got to be quiet. And then they heard this person yelling. What happened to him, he had been thrown off his motorcycle. He landed on the guardrail. Perfectly on the guardrail, like he was riding it or something like that, ended up breaking his hip and also damaging a lot of his other organs at that point. He was very fortunate he did survive this. When the nurses were telling us this, they said, well, he apparently gave up drinking. Rotation and rollovers, a lot of times we're not quite sure what's going to happen to you because you can be spun around in that vehicle, or as the vehicle rolls over, you can become a flying object in it, okay? So you can see the head-on injuries, the side impact injuries, just depends on where you are and how restrained you are. A lot of times if you read some of the injuries, you'll have these babies that are in their car seats that are thrown down the road and things like that, and they're not injured at all. Those car seats protected them from any type of injury. Whereas the person who was driving, if they did not have their seatbelt on, or were not restrained properly, sometimes will travel throughout that vehicle and not survive. Motorcycles, bicycles, we're seeing a lot more bicycles these days. What's really sad is that I don't think we're doing a very good job of educating our children on the rules of the road with the bicycles. And you see these bicyclists, they complain that nobody watches out for the bike lanes. That may be true. I don't blame them for 100% of what happens to them. Sometimes, though, they're also riding in the roadway and they're not watching. They're having conversations and they're going in and out of the bike lane into your car lane. So you really need to be careful. One of the major reasons why bicyclists get hurt or motorcyclists get hurt, nobody's looking for them. If you think about it, and this is something to try this weekend, is see how many motorcyclists or bicyclists you actually see that you probably would not have seen if you hadn't been on the lookout for them. The reason is a lot of times we're looking for something that looks like the vehicles we're driving. And this is somebody who was in a motorcycle accident, and you can see they went down the road. Remember, when you're on a motorcycle, you're not supposed to be wearing halter top shorts and flip-flops. You can see the extended damage on both legs. And back here, there were like 55,000 motorcycle riders, passengers injured per year. Most commonly, the injuries come from laying the bike down or a head-on or an angular impact, okay? Remember, your center of gravity is in front axle, so if you get hit, the bike's gonna go over on you at that particular point. Motorcycle crash are really costly, but a lot of them can be prevented. They can be prevented both by the driver and the vehicle and the motorcyclists themselves. We know that the helmet law has saved a lot of folks. The problem is that we still don't believe it. Okay, in 2013, they figured that helmets saved an estimated 1,600 lives and about $2.8 billion in economic cost. Okay, and it also figures that the United States could have saved an additional 1.1 billion in 2013 if all motorcyclists had worn helmets. They reduced the risk of death by 37%. They also reduced the risk of head injury by 69%. Okay, and it says that only 19 states and the District of Columbia mandate helmet use by all riders. ATVs are another one that we see. We had a student one time who was out riding his ATV, and there were some other people out there, and they were messing around. One of the folks that was messing around took off on his ATV, and then all of a sudden it stopped. It got really quiet. He went to see if he could offer his help, and what had happened was the handlebar was now sitting through the neck of the person on it because of the ATV. They fell on him. Okay. In 2015, 27% of your fatally injured motorcycle drivers were operating without a valid driver's license. Okay. And let's see here. This is kind of interesting. 73% of your ATV riders killed on public roads in 2015 were on rural roads. Of those, 63% were on minor roads. 75% of the fatally injured ATV riders were killed in crashes, okay? And 28% of your fatally injured motorcycle riders in 2015 had blood alcohol concentrations at or above 0.08, which you know is the legal limit here in Arizona. In single vehicle crashes, this was about 42%. In 2009, you had 630 pedal cyclists were killed, and an additional 5,100 were injured. And this accounted for 2% of all motor vehicle traffic fatalities and made 2% of all people injured in traffic crashes during the year. They went down in 2010, went back up in 2012, And it wasn't the kids that caused it to go back up. It was actually the people, adults, that caused that to go up. These are just some things you can look at. It tells you about the data. So in 2013, over 900 bicyclists were killed. Estimated over 494,000 ED visits, okay? And if you can see here, data from 2010 between fatal and non-fatal accidents resulted in a lifetime medical cost and productivity losses of $10 billion. In case you're wondering, trauma is expensive, extremely expensive. Okay. So falls, as you can see, you can slip on ice, a banana peel, whatever else you're doing at that particular point. This is the relaxing moment in this PowerPoint. Okay. So it's the second leading cause of accidental deaths in the United States. More than half will happen at your home. 4 out of 5 will involve older adults, 65 and older. It is the leading cause of injury deaths to these older folks, okay? And you can see it's also the most common cause of non-fatal injuries and hospital admissions and the leading cause of traumatic brain injuries. Now, one of the things we see with these folks that are 65 and older are hip fractures. And unfortunately, about half of the older adults that have these hip fractures never regain full function. Some of them have to give up their home and they have to go live in an assisted care place. Some of them, especially females, and they're still not quite sure why this happens, but we know that more females that suffer hip injuries will end up dying within the first year after that hip injury than a lot of times that are actually survive them. Okay, so this is something that you definitely have to watch. They've done a lot of research on this, and they still don't understand why, but they do know it happens. Other injuries that we see with these folks, forearm, leg, ankle, pelvis, upper arm and hand injuries for them. A lot of times they're tripping on carpets. A lot of times they trip over the grandkids' toys and things like that. So they do have to be careful. What they figured, and this was kind of interesting, so it's actually gone up quite a bit. The estimated cost of a fall in 1994 was like $20.2 billion. By 2020, which was last year, was all the way up to $32.4 billion. Okay. Now, one of the things that we're going to talk about brain injuries, we're going to talk about the cranium. What happens as you age, if you remember, until it takes like from birth to age 10 for the brain to fill up the skull. When you start getting older, then we also know that the brain starts to shrink a little bit. And so what happens is some of these folks will fall and hit their head, and they may have a headache, they may have whatever, they go to the hospital, they rule everything out, and they say everything is fine. But it takes a while for that injury sometimes to show up because you have that little bit of extra space. Doesn't seem like it's possible, but in fact, it's very, very true and unfortunately very risky. So this is somebody who was talking about injuries, and you can see every second of every day in the United States an older adult falls, making falls the number one cause of injuries and deaths for older Americans, and one of the major reasons why they lose their independence. And one of the things that you guys probably know, if you've had family members that have gone through this, they take dad's car keys, he cannot drive anymore. We see a decline in their quality of life, and sometimes that's the end of their life at that particular point. Let's see what I want to tell you about this. One thing too, fall injury rates are almost 7 times higher for older adults with poor health than for those that are in excellent health. And these are just some tables that you can look at. There you see, 1 in 5 will cause a serious injury, broken bones, head injury. Annually, 2.8 million older people are treated in the ED for fall injuries. over 800,000 are hospitalized, and most often are the head or the hip fracture. The question people had too, and this was kind of interesting, they wanted to know, why do people fall? Do they fall because, they get clumsy or something like that? Well, one of the things, and a lot of folks don't know this, as you go hit about age 40, you start to lose your balance, but you don't lose your balance enough to where it's going to become a major concern for you. When you hit about the 50s, you've lost quite a bit of your balance, and that's starting to become a little worrisome. And so then they tell you, take care of yourself, slow down, make sure that you understand what's going on. One of the things too they found out is that older Americans too, a lot of times what happens is they turn, and they may turn quickly, but when they do, their center of gravity doesn't go with them, and they get off balance, and that also causes them to fall. So unfortunately, the answer to a lot of these falls is simply the body aging at that particular point. So you've really got to watch that. And if you have some older adults that are very dear and near to you, take a look at what could possibly or potentially cause them some problems. And then remember, someday you're going to be that older adult also. There's some more statistics. So falls, for the most part, if you fall greater than 15 to 20 feet, you normally end up with a more severe injury. Greater than 15 feet, you can land on your feet. You have time to flip over. Less than 15 feet, you're going to land on however you fell. So if you're sliding off the roof and it's less than 15 feet, you're probably going to land on your head. Children, for the most part, have a tendency to land on their head because they are top-heavy, okay? And the type of surface influence the extent of the injury. I don't know how many of you guys have ever jumped off and, done one of the kamikaze dives into water, and as soon as you hit the water, it felt like concrete. That's part of those injuries that we're talking about. So penetrating trauma, this is when you actually do break the skin. And what happens is you crush and stretch it, whatever it is at that point. And so the type of object, the speed of the object, wherever you hit, is going to show us how much injury actually occurred. And sometimes we can find it and we can trace it. Unfortunately, with the high-powered rifles and things like that, sometimes we don't trace them extremely well. So if you look on this is an injured person who ended up with multiple stab wounds. And if you look at them, you can see that some of these are almost, let me see if I can, what we have here. This laser pointer. Okay. You can see at this point that's in the back and very close to their spinal cord. And depending on the depth, it'll be whether or not they actually got their lung or not. So we talk about energy potentials. There's 3 energy potentials. Low, these are your low velocity injuries. You can know exactly where it went to. If you ever got mad at yourself, you take your pencil and stab yourself in the hand, you know exactly where that pencil went in and came out. Medium, your handguns and some rifles, and we can pretty well track those also. As you saw the beginning slide, very small entrance wounds, but you have like a starburst pattern on the exit wound because you're pushing all of that skin and everything else out at that particular point. And then higher, the hunting rifles, assault weapons, things like that. With bullets, remember they tumble or yaw in the body. As a problem of that, they can go different ways, and then that's how they can cause different damages to the path that we would think it was going to follow, but they actually don't follow it. So what happens is you have the beginning of the injury, the crushing force as the bullet goes through, the temporary cavity formation, and then the collapse of that cavity formation. In this one, you can see, we have, at this particular point, you can see the entrance wound, very small. As it goes through the brain, you can see it's getting bigger. and it could be yawing and tumbling at this particular point, and as it comes out, you have a much bigger area. There's part of the bone, and there's part of the tissue that also goes out with it. So the entrance-exit wounds depend on the range and the barrel and the caliber of the gun. If it's very close to the tissue, for example, people who shoot themselves in the head, we're going to see the round or oval entrance wound, and then the exit wound much larger because of the cavitational wave. And that's where that starburst wound comes into it. And this is one that you can see that it went in, and when it came out, it made a lot of extra room in the brain, unfortunately. And this is a person who had some shotgun wound to the left chest, and you can see the different bullet holes and things that went into it. You can see being a respiratory therapist, that is a non-rebreather, appropriately inflated. Now your neck is kind of interesting. We all love our neck because it keeps our head off our shoulders. But most of the time, if you're going to end up with a neck injury, it's going to have about 44 to 52% of multiple injuries. And if you feel your neck, you know it's not very big for the most part, okay? And if you touch it, you can feel the skin, you can feel the muscles, you can feel the tendons, you can sometimes feel the pulses, the carotid pulse, you can feel the trachea. You got a lot of stuff in your neck, okay, along with your spinal cord and things like that. And because of all that stuff in there, depending on where you get hit, you can have some major injuries to your neck. And they can be both blunt and or penetrating. And this is a person who has a stab wound to the suprasternal notch, okay, and that's what they call the zone 1 of the neck, okay. In this case, the person did get a pneumothorax, however, the blade missed the great vessels of the neck and chest, okay. So what is the initial assessments, ABC or CABDE, which is depending on what's going on. I always start with your CABs. Then while that's being handled, now you can go ahead and examine other things that are going on. Disability caused by, assessed by the neurological examination, expose the body to examine the total body area to see what other injuries have occurred. And we see a Glasgow Coma Score. We talked a little bit about this. Remember, for chapters 1 through 5 in Advanced Patient Assessment, we said, how do you assess what's going on with the patient? You can use the Glasgow Coma Score. The score is between 3 and 15. Now, there are people who are going to tell you, well, I don't think it's really 3. There was a program one time that kept saying, it's 2 or 1, and I'm going, they don't have a clue what they're talking about. It's 3. And the reason is there's 3 different areas that you actually assess. One of them, let's see if we have these. One is the eye, one is the verbal, and one is the motor. The lowest score for all of these is 1. So if you have no eye response, no verbal response, no motor response, that's 3, okay? We can do this on adults, we can do this on kids, we can do these on babies because we look at the responses as far as that goes. So if it's the score is like 13 or above, it's a mild brain injury. If it's between 9 to 12, it's a moderate brain injury. 3 to 8, we do know you have a severe brain injury. And if it's less than 8, for the most part, you're in a coma and you're probably intubated as well. What you need to remember is the Glasgow Coma Score tells me right here and now what's going on with you. It doesn't tell me what's going to be going on with you in 30 minutes. All right? It's here and now, not in the future. So this is what they look at for each of these, just so that you have an idea what they're looking. And that's how they grade it. 1 is no eye opening, 4 is the eyes open spontaneously. Verbal response, 1 is no verbal response. and we go all the way up to oriented. So here's your motor response. 1 is no motor response. There's your 2. And then all the way up to obeys commands. Now, sometimes they'll tell you that the phrase GCS of 11 really doesn't mean much. What they really want to know is what is the I, what is the verbal, and what are the motor reactions to it, because that tells us more about what's going on with these patients. Now, we've all had external bleeding. We've all cut ourselves or, doing things we're probably sometimes not supposed to, or those paper cuts are really, really, we can see the external bleeding. And serious wounds damage blood vessels. Arteries are always nice and red for you, veins a little bit darker. And if you're bleeding, you can have pumping and gushing about a pint of blood. So what type of wounds can you have? An incision, a laceration, abrasion, puncture, all the way up to amputation at that particular point. Internal bleeding is not always that easy to see. Okay, blood can leak into the body spaces, can be caused by blunt trauma, a sharp object. We always need to be suspicious about this. And if you start to see your patient become pale, cool, clammy, all of the signs of shock, there's some bleeding going on. It was unfortunate. This happened many, many years ago. There was a gentleman who was in an accident. They were really concerned about him. He had lost his wife a couple of weeks before. He had his 2 daughters at home. He wanted to go home. They went ahead and they knew he wasn't doing well, but they went ahead and they sent him to the CT scanner. They did everything else they could. They didn't see any bleeding. They couldn't track any bleeding. And he said, I've got to go home. I've got my 2 daughters at home. He went home, and unfortunately, they had brought him back a couple hours later. He had internal bleeding and actually passed away. So talking a little bit about blood clots, we talked a little bit about blood clots this morning. It's a 3-part process. The endothelium, vasoconstriction, platelets, and coagulation. All of those good things do it. What happens though is, remember, clots don't last forever. There comes a point in time where they're actually going to leave, and this is your dearrangement of it, okay? And what causes this is hypothermia, acidosis, and hemodilution. So we always have to be prepared for it. Now, if you see somebody, say somebody has a wound and you want to help them stop their bleeding, you can take a cloth, whatever else you're going to use, and press really, really hard on it and hold it. And if they're awake, ask them to do it, because people will have a tendency to put more force behind it than we do in some cases. You don't want to pick it up and look at it, because if it's clotting, you just broke the clot. And so what you want to do is continue to pile more on there and keep pushing it until they get some help, okay, as far as that goes. If you ask somebody to help you, like I said, a lot of times, if it's somewhere in their abdominal cavity, sometimes they can lean on it. If they can't hold it, but they can lean onto it, and if they can lean onto it, that'll also give them some pressure and help to stop that bleeding. And here's a nice picture of a blood clot formation. You see those fibers, that's the platelets. There's your red blood cells. There's the platelets that haven't gotten involved yet. A little bit of history of trauma. This came from one of the Army manuals for training. And this person has something going on with their ribs, possibly broken ribs. And you can see what they did is they went ahead and they put these pins in, and then they would hook these pins up and then pull it up so that the person would be able to breathe. Looks pretty comfortable, I guess. So chest wall injuries. You can have a simple rib fracture, you can have a flailed chest, you can have other injuries to the chest. If there's any tenderness over the rib area, suspect a simple fracture or a fracture, okay? You may also have to do both inspiratory, expiratory x-rays for a pneumothorax. That shows us all the air at that point. The level of the rib injury indicates some of the problems that you're going to have. And one of the things that I mentioned in the video this morning is if you have a fracture of the clavicle and of the first rib, we need to go in and figure out what's going on. And sometimes the second rib, because sometimes what will happen, it'll actually cause the aorta to be disrupted, and the person can actually bleed to death. So we need to be aware where did this injury occur and what are we looking at this particular point in time. With a flail chest, remember paradoxical movement. With a flail chest, you've lost the integrity of the chest cavity. What happens is as you breathe in, instead of going out, it collapses in. When you exhale, then it goes and pushes out. You can start off with an open pneumothorax and end up with a tension pneumothorax. One of the things that we can do with a pneumothorax is they'll tell you, take like a card or whatever, put it over it, and then tape it on 3 sides, leave one side open. That way when the person exhales, the gas can leave the pleural space. This is kind of an interesting one. It says Table 7-1, Major Thoracic Injuries. And you can see airway obstruction, tension, pneumo, cardiac tamponade, open pneumothorax, massive hemothorax. We're going to talk a little bit about those. And there's your flail chest. The hidden 6 are the traumatic rupture of the aorta. There's your first rib that's broken and sometimes your second. Major tracheobronchial disruption. We're going to talk about that. A blunt cardiac injury. What's interesting is they were telling us a story one time. This person was driving and they got into an accident. And when they did, they went and found him and he was dead. And there was not a mark on him and they couldn't figure out what had happened to him. And when they brought him to UMC, they opened up his chest and it was full of blood because his heart had actually ruptured. And what they had and thought is that he was inhaling and had just exhaled, which moved the heart much closer to the chest wall, and he hit the steering wheel and that caused his heart to rupture. Diaphragmatic tear, we're going to talk about that. We're going to talk about esophageal perforation and a little bit about pulmonary contusions. So pneumothoraxes, we hear a lot about pneumothoraxes. Remember, they can be simple pneumothoraxes. They can happen spontaneously. They can be results of whatever else is going on with these folks. It's basically positive pressure in the pleural space. Okay. You can have an open, a closed. It can be punctured from a rib fracture. You can have a ruptured bronchus that's going to cause this. Remember, gas always follows the path of least resistance. You can also have a perforated esophagus that goes into the mediastinum, which now puts air into the pleural space. If you notice, one of the cardinal signs of a pneumothorax, loss of vascular markings. If you look at this, you can see the arrows are pointing to what's going on. There's your lung. There's part of the problem at this particular point where the opening is. No vascular markings. There is your pneumothorax. And over to this side, you can see very hazy, so there's some other things going on over here. This is a stab wound in the back, and if you look at it, this is a good possibility that that could also end up with a pneumothorax. And on the slide here, you can see the pneumothorax in this area down here. Okay. So what are some of the signs and symptoms of a pneumo? very minimal on occasions to severe dyspnea. I believe I told you the story about this young lady, wasn't feeling well, went to see her doctor, he didn't find anything wrong. She went back a little bit later, a couple of days later, said she still really wasn't feeling too well. He sent her for an x-ray. She said, thank you very much. She went out shopping. Doc called the Tucson Police Department, asked him to go find her because she actually had a pneumothorax that was going to start to get worse. Okay. We can also see shock, life-threatening respiratory failure, circulatory collapse. That's why they went and got her. Hypoxemia, hypocarbia, hypotension, all of those different things. A sudden sharp pain. We talk about this in mechanical vent, that these patients are on ventilators, doing whatever they do on ventilators, like sleep or relax or try to heal, and all of a sudden they'll sit up, the alarms are going off, and we look at them, and sometimes what's happened is they've actually had a pneumothorax occur. You have a dry cough at onset, and if this is a slowly developing pneumothorax, it's not quite as severe. How do we treat it? Less than 15%, it reabsorbs itself within 15 days. Over 20% may take 2 to 4 weeks. And we can actually aspirate this with a small bore catheter, which is a needle or end of a needle. And your air leak will sometimes close rapidly, okay? We can see pulmonary edema after reabsorption, especially by altering the pressure within the thoracic cavity. Now, one of the places you put the small bore tube, you go out to about where the armpit is, and you come across into like the midclavicular area, and you can put a small bore catheter in there, and you should hear whoosh, and that's if you're treating that pneumo. Tension pneumos, a little bit worse than a normal pneumo. Can happen with blunt or penetrating trauma. It can also happen because of the open pneumothorax closes. This is your check valve. The air comes in. It's not going out of the lung. And there you see you have an increased interpleural pressure, but you're not getting rid of the gas. This causes decreased venous return, decreased cardiac output, cardiovascular collapse, and shock. Now, if you look at this, you can probably tell this is an X-ray. If you look really close, you can see that the heart is not on the left side anymore. You can see all the air over here. This is your tension pneumo. And if you can follow these two, you can see where the great vessels are, and the trachea has been pushed over off on one side. So what are the signs and symptoms? Diminished breath sounds because you have nothing going in except the air is not coming out. Decreased chest wall movement. There's your tympany or hyperresonance. Don't worry about tactile fremitus. You won't hear that. Respiratory distress, shock, tracheal shift. Normal pneumothoraxes, I know we talk about this. It will tell you that if you have a normal pneumothorax, you have a tracheal shift. If it's a minor or small pneumothorax, you're not going to feel that tracheal shift because the tracheal shift is down below the suprasternal notch, okay? With a tension pneumo, you will feel that tracheal shift. And you are going to have some subcutaneous emphysema or crepitus. This is a bilateral tension pneumo. Your heart, your lungs, and everything are in the center here. You've got to do something, you got to do it quickly. This is not one that you want to sit there and debate. You need to do a needle thoracostomy. You need a chest tube. When you're putting the chest tube in, if anybody tells you they had a chest tube, a lot of times they're going to tell you it's extremely painful, and I will tell you it is extremely painful. We don't have time to numb you up. This is not a nice procedure, okay? And so you're going to have to get that chest tube in there to release that air. You need IV access, you need some fluid, and you definitely need oxygen because you don't have much of it. Remember, you're going to be hypoxemic, hypotension, hypercarbia, all of those different things. So you got to be careful with that. This is a right tension pneumothorax. There's a mediastinal shift to the left, depression of the right hemidiaphragm. Because remember, this diaphragm is higher than on the left, but look at this one. This is the same level as the left. So the liver is also being pushed down at this particular point. Here's your needle thoracostomy. Just put it in. Hemothorax, that can also be life-threatening. This is blood in the chest cavity. Something has ruptured, something has broken at this particular point. Same as blunt or penetrating injury. This can also happen as a result of the pneumothoraxes. So you can have pneumohemothoraxes occurring at the same time, and you can have two chest tubes, one high for the pneumo, one low for the hemothorax. You have severe hemodynamic compromise because you don't have much blood. You're going to end up in hypovolemic shock, and then you're still going to have that mediastinal shift. And these are some of the conditions produced by your chest injury. You can see the pneumothorax there. There's the air in the pleural cavity. Here's the hemothorax, and here's your hemopneumothorax or pneumohemothorax, whatever. So what do? There's diminished breath sounds, a dull percussion note, okay? Fluid is consolidation. It's a dull percussion note. You're hypotensive because you don't have anything to push around. Because you're hypoxic, you're also tachycardic and tachypnic. Respiratory distress, because now you have something that's impeding upon your lung. You are going to end up in shock, and you're going to be cyanotic and have chest pain. How do we treat this one? ABCs, CABs, just depends on the state you're in when you're brought in. We got to give you some lost volume. We got to stabilize you. We got to get that blood out of there because it doesn't belong there. We have to re-expand that underlying lung. You have to be careful re-expanding it because you're also going to end up with pulmonary edema if you do it too fast. You may have to